Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 15th session in a series of 30, Pulmonary Function Testing, Part 7, Tests of Small Airway Disease. So this is the Great Adventure, Pediatric Pulmonary Physiology, and as you can see, we're moving right along, and we want to approach this with the enthusiasm of a kid in a candy shop. So the distribution of ventilation, and abnormal pulmonary function are basically determined primarily by two things: decreased distensibility or stiff areas of lung, and you can see that if you take an inhalation, more air is going to go here than here, and airway obstruction, which again, if you take an inhalation, more air is going to go over here than here. So today, we're going to take a little bit of a historical journey, but we're going to talk about some less commonly used pulmonary function tests that you should be aware of. You may never use some of them, but you should be aware of them. So we're going to talk about the challenge of detecting early lung disease. We're going to talk about the Vmax 60, closing volume, frequency dependence of dynamic compliance, the volume of isoflow using helium, and sensitive tests of lung function. So first, the challenge of detecting early lung disease. So here was the dilemma. The U.S. Surgeon General released Smoking and Health, a massive study of the adverse effects of smoking on lung disease, cancer, cardiovascular disease, etc., on July 11th of 1964. The problem was that there were a number of patients that had chronic obstructive pulmonary disease, primarily emphysema, as shown here. And if you have a situation like this, a huge amount of hyperinflation from very severely obstructed airways due to emphysema, you can't really change the course of emphysema when it's this far advanced. You can see again, basically in the emphysema situation, there's decreased elastic support of airways, and there's just all this destruction of alveolar walls here. So the question became, what if we could detect COPD earlier? Most airway resistance is in large airways, but small airway obstruction escapes detecting by conventional pulmonary function tests, like FEV1, FEF25, 75, etc. And just to remind you, normally 80% of airway resistance is in the large airways or central airways. If we were to double airway resistance in large airways, we'd make a significant impact on overall airway obstruction, and a patient would know that. On the other hand, if we have only peripheral airway disease, a doubling of peripheral airway resistance is hardly noticeable, and therefore small airway obstruction is silent until there's advanced disease. And the thinking at this time was that we needed new tests to detect early small airway obstruction. What if we could detect COPD earlier? We might be able to make a difference in the course of the disease, and if we could treat it earlier. And this hypothesis led to a search for sensitive tests of small airway disease in the 1960s. If we look at the ability to detect loss of physiologic function versus actual physiologic function, the ideal would be that if you lost 25% of physiologic function, you would be able to detect that loss. This is ideal. It doesn't happen. The clinical situation, patients can lose a lot of lung function before we know it, right? Even pulmonary function tests, although they can improve it, they're not perfect. And the hypothesis of thinking was that if we had tests of small airway disease, that this might come closer to this ideal line as shown in green. So to test this hypothesis, we need a group of people who have small airway disease, but normal spirometry. And so this was primarily a quest in adults, of course, because COPD is an adult disease, not really a pediatric disorder. So asymptomatic cigarette smokers do have small airway obstruction, but it may not be severe enough to be detected by spirometry. The idea was to perform new tests of small airway disease on asymptomatic cigarette smokers and see which one is abnormal the most, right? And the four that really emerged and were popular in the 60s were the closing volume, the Vmax 60, frequency dependence of dynamic compliance, and the volume of isoflow. So let's start. Vmax 60 we have discussed, but let's just do this again to remind you. Children have very different sized lungs depending on age, growth, and medical conditions. Maximal expiratory flow rates and airway resistance are best predicted by lung volume. This was the work of Zapletal and Murayama. You cannot understand maximal expiratory flow rates without knowing the lung volumes at which they are measured. So Zapletal and Murayama showed that maximal expiratory flow rates are best corrected by total lung capacity. And if one could measure maximal expiratory flow rates as the flow at 60, 70, and 80% of total lung capacity measured from zero lung volume, okay, um, and then to correct for lung volume, these were expressed as TLCs per second. So what that means is if somebody had a total lung capacity of 5 liters and a flow rate of, let's say, 7.5 liters, that would be 7.5 divided by 5, or 1.5 TLCs per second. And that's shown here. So we're going to look from an absolute volume scale here from 0 to residual volume. Then this is the maximum expiratory flow volume curve. And at 60, 70, and 80% of TLC, we're going to look at what these flows are, but express them as TLCs per second. And recall that because this corrects for lung size, these normal values are mean and standard deviation, not a regression equation. And these are the normal means, standard deviation, and then abnormal would be below these levels. Unfortunately for this test, the normal range is quite wide, but I think they're still useful in terms of helping us out, as we've talked about earlier. So how can Vmax flow rates help us to better understand airway obstruction? Children with hyperinflation may have normal flow rates, but are flow rates normal at the increased lung volume at which they were measured? Children with restrictive lung disease have decreased flow rates, but are they decreased in excess of the reduction in lung volumes? So if this is a maximum expiratory flow volume curve plotted on an absolute value scale here, if somebody is hyperinflated, uh, even though the curve looks similar to what it did before, because there is more residual volume, these flow rates actually are lower than they should be by predicted values if they were measured at normal lung volumes. Similarly, for restrictive disease, this is a curve that has decreased flows, but when you plot it on a absolute volume scale, you can see that for the volume at which it was measured, they are in fact normal. This would be an example of airway obstruction in addition to restriction, where the flow rates are even less than the predicted normal, even for the decreased lung volume. So expiratory flow rates correlate best with lung volume. Vmax 60 corrects for lung volume, and if expiratory flow rates are technically normal, but the child is hyperinflated, the Vmax 60 will be decreased. Flow rates are not normal at the lung volume where they were measured in that situation. So there are a number of studies here that have shown that the Vmax 60 is, in fact, more sensitive than other tests. So this is a group of CF patients, cystic fibrosis patient with mild lung disease. And this is the percent of abnormal tests. And you can see the one that's abnormal the most is the Vmax 60. All right. Residual volume is up there as it always has been. Arterial PO2 is up there as it always has been as well. So this ends up being a very sensitive test to detect abnormalities where spirometry often is not as good. This was a study done by David Botter, one of our pulmonary fellows, and you can see here he looks at the Vmax 80, 70, and 60 in young adolescents who had BPD as infants compared to controls. And you can see the Vmaxes are in fact decreased in BPD across the board, Vmax 60, 70, and 80, compared to the controls. This was studied by Soumya Swaminathan, who looked at, again, school-age children who had experienced meconium aspiration syndrome in infancy versus controls. And again, you can see that all of the Vmaxes, with the exception of Vmax 80, are decreased in the meconium aspiration group compared to controls. Vmax 60 is here. So let's look at closing volume. So closing volume is performed as part of the single breath nitrogen washout test. So the way this is performed, that one breathes along quietly, takes a maximal inspiration of total lung capacity to get a constant volume history, exhales to residual volume, takes an inspiration of 100% oxygen, and then gradually exhales that, and the nitrogen concentration is measured So the curve looks something like this. Here is 100% oxygen in conducting airways. This is the so-called alveolar plateau. The slope of that determines the uniformity of distribution of ventilation. Should be less than 2.5. And closing volume is where this little blip occurs here, phase 4 of this curve. And it's quantitated as from this blip to residual volume as a percent of vital capacity. So a higher value is bad because it means airways began to close earlier in exhalation. It is a sensitive test of small airway obstruction, but it's not seen with abnormal pulmonary function such as FEV1, FF25, 75, or peak flow. It does collide with elastic recoil of the lungs, and again, it's measured as exhaled lung volume where airway closure begins. So higher values indicate disease. Here's how this works. If we have someone upright, okay, in the apex of the lung, airways are larger and alveoli are larger. So ventilation is actually less because there's less difference between the volume at rest and the maximal volume. At the lung base, airways are smaller, so ventilation is actually greater because there's more difference here between rest and the maximal value. And this is because elastic recoil is greater on the airways up here, opens them up more than it is down here. At the lung apex, when we inspire 100% oxygen, the fraction of alveolar nitrogen is higher because there's less oxygen that dilutes this. Remember, these lungs all started with 78%, 79% nitrogen. So in this case, the nitrogen is less diluted than it is down here. So the fraction of alveolar nitrogen will be lower after 100% oxygen inhalation in the base than the apex. Now one starts to exhale. The lung base airways closed first. Remember, first in, first out. Best ventilated airways open first on inspiration, exhale, close first on exhalation. So this has a lower, these airways close because there's lower airway size. These have the lower nitrogen concentration, all right? So now the only nitrogen contributing is in the upper airways, which remain open and have a higher nitrogen concentration. And that's what causes that blip upward. So basically where this occurs, it means that airways in the base have started to close. Now, if you have a high slope of phase 3, that is, if you have a significantly non-uniform distribution of ventilation, you can't really find the slope of phase 4 or the phase 4 here, the closing volume. So this is a test that only can be done in people with normal spirometry and reasonably normal slope of phase 3. Tony Mansell, he was a junior faculty member at Toronto at the Hospital for Sick Children when I was there. Subsequently went to Brown, did this classic study and showed that closing volume correlates with elastic recoil. The lower your closing volume, which means the better, your airways are less likely to close, the higher the elastic recoil keeping your lungs open. Those patients that as they lose recoil, closing volume increases. Now, this is the plot of elastic recoil, which you might notice is exactly the inverse of that other plot. So here, elastic recoil peaks at around mid-adolescence, early adulthood, falls with age. Remember that the tidal closing volume fell till about this same time, age 20 or so, and then increased with age. Here's that curve again. So again, the highest closing volume basically falls till about the same place as the peak of the elastic recoil, 16 to 20 years, and then rises again as adults lose alveoli with increasing age. This shows FRC minus closing volume. So negative volume values indicate airway closure even during tidal breathing. So I'm not even on this scale, unfortunately, but certainly people above, let's say, late 40s, 50, they have airway closure occurring even during tidal breathing. Some very younger children do. But again, in this 16 to 20, 24 age, when pulmonary mechanics are optimal, airway closure does not occur in tidal breathing. It only occurs below FRC. Now, closing capacity, right, is the same measure, but in this case, it's based on total lung capacity. So it would be total closing volume plus RV. And so closing capacity based on total lung capacity, a fraction of total lung capacity, after which airway closure begins. Closing volume is based on the vital capacity. This study again of closing volume detects abnormalities in CF patients with mild abnormalities. Um, this is the closing volume. This is the closing capacity. Was more sensitive, but partly because of hyperinflation here. But a reasonably sensitive test. This was Swami-Nathan's study in school-age children following meconium aspiration syndrome during infancy, and you can see the closing volume was significantly different, significantly greater in the meconium aspiration patients. And remember, that's bad, okay? And the slope of phase 3 was not significantly different between. All right, frequency dependence of dynamic compliance. So compliance, recall, equals change in volume over change in pressure. So pulmonary compliance uses transpulmonary pressure as the pressure, which is alveolar minus pleural pressure. Chest wall compliance could be measured and would use barometric minus pleural pressure. What's between these is the chest wall. And total respiratory system compliance uses barometric minus mouth pressure. So this is the pressure walk that we've talked about before. And again, if we're looking at the lungs, what's between the alveolus and the pleura is lung tissue. And that's really what we're concerned about here. So remember pulmonary compliance, if we plot pressure versus volume, this is the volume achieved for change in pressure. You have an inspiratory expiratory limb, there's a slope, this slope is the pulmonary compliance. Remember also the equation of motion of the lung. Pulmonary compliance is composed of pressure to overcome elasticity and pressure to overcome flow. So again, we can calculate the elastic component. We know that compliance equals volume over pressure, so pressure, elastic pressure equals volume over compliance. For resistance, resistance equals pressure divided by flow, and the resistance pressure is resistance times flow. So this is the equation of motion. PEL is volume over compliance. Resistance is resistance times flow. If we measure static pulmonary compliance, we're measuring these at points of no flow. So we're only measuring change in volume over change in elastic pressure. If we measure dynamic pulmonary compliance, that is, as a person is breathing, right, this is going to be change in volume over change in elastic plus resistance pressures. In large airway obstruction, increased airway resistance will decrease dynamic pulmonary compliance compared to static pulmonary compliance. Dynamic compliance reflects small airway obstruction due to lung regions with non-uniform prolonged time constants. Okay, it takes 5 time constants to fill a region of lung. So the time constant of peripheral airways, that is less than 2 millimeters, is estimated to be about 0.01 seconds in normal adults. So for a time constant of 0.01 seconds, the normal estimated time constant, it takes 5 time constants, so 0.05 seconds to fill a lung region. At a respiratory rate of 20, inspiratory time is 1 second, so there's plenty of time. At a respiratory rate of 120, inspiratory time is 0.17 seconds, so there's still plenty of time to fill lung units at rates of 20 or 120, and there will not be frequency dependence of dynamic compliance. However, let's take a patient with lung disease who perhaps has a time constant of 0.04, 4 times increased. So it takes 0.2 seconds now to fill a region of lung. At a respiratory rate of 20, the inspiratory time is 1, and so there's plenty of time to fill that region of lung. But at a respiratory rate of 120, the inspiratory time is 0.17 seconds. There is not enough time to fill lung units at that high rate, and therefore there will be frequency dependence of dynamic compliance. That is, the compliance will decrease. So frequency dependence of dynamic compliance may be used as a test of peripheral airway obstruction. It reflects small airway obstruction if obstruction is irregularly distributed, some airways open and some closed, and if the static pressure volume curve is normal. Also, you want normal airway resistance in the large airways. So to measure this, you first need to measure standard pulmonary function to assure there are no abnormalities in spirometry or standard pulmonary function tests. If abnormal, spirometry, frequency dependence of dynamic compliance, will more likely be due to large airway obstruction. And you cannot detect small airway obstruction in the presence of large airway obstruction. Again, this test is influenced most by differences in regional time constants, causing flow into small lung units to be non-uniform. Breathing at a higher frequency makes this non-uniformity worse because there's not sufficient time for units with long time constants to fill, and this occurs at the level of the small airways. So second is to measure static pulmonary compliance, and as you recall, this needs an esophageal balloon, and we previously described how we do. And this is a study by Ann Woolcock that looked at 5 COPD patients, 2 asthmatics, 8 controls, all in the adult range, but young adult range, with normal PFTs. And you can see that this group also had normal pressure volume curves or normal compliance. You're then going to measure dynamic pulmonary compliance at increasing respiratory rates up to 120 breaths per minute. So you're going to measure volume and PTP at points of no flow. So here's what happens, is we're breathing along, here we're breathing a little bit faster, here we're breathing a little bit faster. To get the same tidal volume, you're going to need increased pressure. So the points of no flow are going to be the volume changes here and the pressure changes here. So take an inspiration of total lung capacity to establish a lung history, then take even tidal volume breaths at different frequencies up to 120. Calculate the dynamic compliance at each frequency and express dynamic compliance as a percent of static compliance. So here's what you're doing. So here we have a normal individual. Here's compliance at increasing frequencies, and you can see there's no change. Here's an individual with small airway disease, and as this person increases, you can see that compliance falls. So this is frequency dependence of dynamic compliance. So this, again, study by Ann Woolcock, shows dynamic compliance or frequency dependence of dynamic compliance in a number of normal subjects, which are primarily up here, and a normal of subjects with bronchitis who do show some degree of frequency dependence of dynamic compliance. This again is a group of normal individuals and asthmatics, who in this case have a decrease. These are a group of bronchitis patients before and after bronchodilator inhalation. And note that there's not much change. And the reason is that frequency dependence of dynamic compliance is measuring primarily small airway function. But asthma, or the action of bronchodilators, is in the large airways. Here we have, again, before and after, we have some controls. With the exception of this guy, no difference. And these asthmatics, again, there's no difference pre and post. This is a subject before, during, and after an acute bronchitis attack. And there does seem to be a little bit of a change in this individual during the attack. Adolescents with asthma, 7 of 15 did show frequency dependence of dynamic compliance, suggesting that they had small airway disease in addition, and 2 had this even after inhalation of the short-acting beta agonist, again pointing out the fact that this is not due to large airway. Now the problem is that these particular investigators performed this test 2 to 4 times on 15 normal subjects. They found poor reproducibility and wide scatter. They were unable to improve variability despite multiple maneuvers, and these investigators doubt the value of this test in view of the high variability in normal subjects. And to be honest with you, I really haven't seen examples of this test being used in the last several decades. So, well, it was an interesting idea, and there were some preliminary effects, I think, for the average laboratory to try and produce this with any reproducibility is unlikely. So this is a test that is of historical interest, but we'll probably never use. This basically depends on turbulent versus non-turbulent airflow. So in the large and middle-sized airways, airflow is turbulent. In small airways, however, airflow is laminar. Turbulent flow requires acceleration, that is, change in direction of gas molecules. Heavier molecules are resistant to acceleration. Remember from physics, force equals mass times acceleration. Helium has an atomic weight of 4 and a density of 0.179 grams per liter at STPD. Nitrogen, which is 80% of air, has an atomic weight of 14 and a density of 1.251 grams per liter STPD. So nitrogen has 7 times the density of helium. In large and middle-sized airways where flow is turbulent, right, a lighter gas will have a higher flow than a heavier gas. Helium is lighter than nitrogen, so helium will have a higher flow than nitrogen where flow is turbulent. However, in small-size airways where flow is laminar, laminar flow does not involve acceleration of gas molecules. Thus, flow is not influenced by gas density, and helium will have the same flow as nitrogen where flow is laminar. So what one does is during a forced exhalation, flow is initially turbulent in large and middle-sized airways, and then flow becomes laminar when gas gets to small airways. The lung volume at which helium and nitrogen have the same flow is where gas enters small airways, and this is called the volume of isoflow. And here's how it is measured. So here we have a standard maximum expiratory flow volume curve breathing air, so 80% nitrogen. And here we have a curve after breathing helium, and you can see that indeed the flow rates in helium are higher in turbulent air, but as it approaches small airways, these come together, and this is the so-called volume of isoflow, the volume where expiratory flow is equal between the helium flow volume curve and the nitrogen flow volume curve. Now, the volume of isoflow is measured as lung volume from residual volume to the point where heliox and room air maximum expiratory flow volume curves meet, and it's expressed as a percent of the forced vital capacity. Higher volumes indicate more small airway obstruction. Narrow airways act like small airways, so laminar flow occurs earlier in exhalation at higher lung volumes. So for a volume of isoflow, a higher volume is bad. It means you have more, if you will, small airway disease. So to measure this, we measure the maximum expiratory flow volume curve breathing room air, and then you breathe heliox, 79% helium, 21% oxygen, to wash nitrogen out of the lungs for 10 minutes. That's the standard. Then you repeat the maximum expiratory flow volume curve breathing heliox. Do not let the subject breathe room air between heliox maximum expiratory flow volume maneuvers, and then you match the curves to determine the curve where they meet. So this was a study done by Meyer Catan, who was a fellow with me at the Hospital for Sick Children in Toronto, and he looked at young adolescents who were asymptomatic. They were not being followed in pulmonary clinic for any reason, 10 years after RSV bronchiolitis. And you can see that the majority of these children who were asymptomatic, in fact, had abnormalities in the volume of isoflow. Only a few were in the normal range here. And you can see this is the same study. About a third of subjects overall had a combination of abnormal PO2, volume of isoflow, and hyperinflation. About a little over 60% had abnormal volume of isoflow. All right, so let's just kind of put it all together. This study, again, Meyer Catan study, asymptomatic adolescents after bronchiolitis with normal spirometry, normal FEV1, FEV1 over FVC, and AFib 2575. 70% had hypoxia, 57% had an abnormal volume of isoflow. Hyperinflation was up there, Vmax 68 was abnormal in few. And again, there's his data. Patients with mild cystic fibrosis, a study cited by Henry Levison and Simon Godfrey. Again, in this group of patients with mild lung disease, again looking for the most sensitive, relatively few had spirometry abnormalities, but almost 90% had abnormal volume of isoflow, even more than had hypoxia. A different test by Cooper and colleagues showed that Vmax 60 was a sensitive test. Asymptomatic adolescents after bronchiolitis, Meyer Catan study, with normal spirometry did show a fair number of these patients had hyperinflation. Again, a study cited by Levison and Godfrey, PO2, residual volume, in terms of standard spirometric things, hyperinflation is much more sensitive than flow rates. This was another one by Cooper in cystic fibrosis patients with abnormal, and again, hyperinflation was the most sensitive. This is asthmatics, not during an exacerbation. Again, hyperinflation was most sensitive. A different study by Cooper, same thing, hyperinflation, more sensitive than standard. And these were children with normal spirometry, I should say. BPD infants, children had BPD as infants, basically had a statistically increased residual volume. Other spirometric tests were not significantly different. Survivors of severe BPD as adults, the residual volume actually increased with time. So here they were studied as children, and here they were studied as adults. Somi Swaminathan, Pulmonary Fellow, Children's Hospital, Los Angeles, looked at children who had meconium aspiration syndrome as infants, and these was relatively mild. These were not babies who went on ECMO. At age 8, gestational age and birth weights were comparable. Again, total lung capacity not different, vital capacity not different. Residual volume increased. Flow rates not different in her study, but the Vmaxes were. Vmax 60 and Vmax 70 significantly lower in the meconium aspiration patients. Vmax 80 not different. And as we alluded to, closing volume was abnormal in this group, but not slope in phase 3. Rafika Hamucha Ursu, a pulmonary fellow at Children's Hospital, Los Angeles, 1998-2001, looked at 50 children who had ECMO for neonatal respiratory failure, compared to 27 controls, mean age around 11. Gestational age and birth weights are shown here. The cause of or the reason for the use of ECMO was meconium aspiration syndrome in most, sepsis and pneumonia, congenital heart disease, persistent pulmonary hypertension in the neonate, and respiratory distress syndrome. By the time of her study, that is Dr. Hamuchu's study, all of the cardiac lesions had been completely corrected. Total lung capacity not different, vital capacity not different, hyperinflation, seen a pattern here. Flow rates decreased. So in terms of sensitive pulmonary function tests to determine or detect early small airway obstruction, residual volume is generally more sensitive than spirometry. Other tests of small airway disease are abnormal more frequently than conventional PFTs when they are used. Now, they're oftentimes not measured, so we don't see those in most studies. Closing volume and Vmax 60 are the most practical tests. The volume of isoflow is a little bit hard because it requires a helium source, and you have to keep people on helium for about probably a total around 15 minutes for the 10-minute washout and doing a series of maximum expiratory flow volume maneuvers. So, what have we learned? Tests of small airway disease were developed to detect early lung disease. The most sensitive test is the one that is abnormal the most often in a group of patients that you suspect have disease. The 4 classic tests are the Vmax 60, closing volume, frequency dependence of dynamic compliance, which probably is dead at this point in time, and the volume of isoflow for healing. Next time, we're going to leave the pulmonary function laboratory, and we're going to talk about pulmonary circulation and in defense of the lung. So thank you again to our producer director, Katie LeWinter, and thank you so much for joining us for the great adventure, pediatric pulmonary physiology.